Our next speaker is Nilesh Balar, who's going to come up and talk to us about DCBDES therapy and the infrainguinal interventions. Should these stents be the first choice based on the data?
All right, thank you. And the topic is interesting, and the answer is probably yes, but we'll go through the data. And I have no disclosure for this topic. The technology that we have for DCB basically uses paclitaxel as the excipient, and the way it is designed is the excipient would be either urea-based or polysorbate sorbitol or polyethylene glycol. So there are the three balloons that are available, and sirolimus is the new technology that is the Meta-Alliance trial that's being used. And we'll go through the data on each one and see what it shows. So we have the long-term data, at least for 5-year outcome from IMPACT SFA randomized trial. So if you look at that, there was definitely a benefit using the DCB compared to the standard PTA, and it lasted for almost 5 years. So there is a huge difference, and the delta is 9.2% based on the data that we have. If we look at each individual, we have talked about whether it's effective in Rutherford 2, 3, 4, or is there a difference between diabetes, or would the age affect it differently, or the lesion length, whether it's 5 centimeter, 10 centimeter. The advantage persists when you use any drug-coated balloons. We are looking at the result at 5 years. Clinically driven target lesion revascularization was much better compared to pure PTA, at least in the femoropopliteal lesion. Now, if we look at the COMPARE trial where the drug dosage is less, it's 2 micrograms per square millimeter. And those two balloons, if you look at that, the primary patency between Ranger and IMPACT at 2 years is definitely similar, and there's no difference. If you look at the StellarX, which is another balloon with same paclitaxel as the excipient, and it's 2 micrograms, and both of those have the same outcome, Lutonic, StellarX, and Admiral. The outcome definitely outweighs the plain old balloon angioplasty. So the data is consistent. Data continues to show good result and outcome over a period of time. And the only difference, there's minor difference in if it's an amorphous versus crystalline, there is some outcome in terms of embolization and other stuff. But overall, when we compare it to plain old balloon angioplasty, there is definitely an advantage noted throughout. Let's look at the sirolimus as a new drug, and that also shows better data compared to plain old balloon angioplasty. And it's 2 years that we have the data. So as far as the balloon goes, I think the answer is that it's better to use drug-coated balloons for the patency. Now, if we look at the stent technology, again, the stent technology could be coated stent or drug-eluting stent. And we have Zilver PTX and Alluvia that has the data that's more sustained and robust over the period of time. Both of the drugs are there. It's paclitaxel-based, but if you look at the drug release over a period of time, there is a difference between the Zilver PTX and Alluvia drug elution over a period of 360 days or a year. There is continuous drug distribution from the Alluvia compared to Zilver PTX. And if you compare that to DCB, there's only about 30 to 60 days before the drug disappears. So if we look at the data on Zilver PTX 5-year results, we see a persistent freedom from TLR up to 5 years, and it's better than either the standard care, which was the bare metal stent versus balloon. And if we look at data that's compared between Zilver PTX and the Eluvia drug-eluting stent, there's a minor advantage with the Eluvia because of prolonged drug elution over a period of time. So here is the data compared to both the technologies over 5 years. And if we look at multiple studies across the board, if you go from the left to right, DCB, bare metal stent, drug-coated stent, and drug-eluting stents, there are multiple trials. All you see is that clinically driven TLR is better with drug-eluting technology. You don't have to re-intervene compared to bare metal stent and pure balloon angioplasty. So in conclusion, the data definitely supports the use of DCB and DES as a primary treatment therapy for infrainguinal PAD, especially SFA and POP segment. Below the knee, therapy is not clear. The results were very different. There's still new technology and new bioabsorbable stent studies being done, which are promising. And the current data has not made it to our official guidelines. That's why there was the discussion in the morning case whether we should use plain old balloon angioplasty as a primary treatment, and then if it fails, then we use the drug-eluting technology. So the unanswered question that remains now is, do we use DCB and drug-eluting stent technology together, or we use the plain old balloon angioplasty and drug-eluting stent as a technology? So those are the only remaining questions, but as far as the data goes, there is definitely enough evidence that there is a benefit, and financially it may not be as advantageous. Thank you again for the time.